So let's move on with continuing here. Potential nursing diagnoses for infections. Common. This is obvious. Risk for infection, risk for injury to self, ineffective management and therapeutic regimen. Of those three, risk for infection is probably the biggest priority, simply because that's going to make them sicker and or deader. So let's talk about labs. Antibiotics. Now, there are a number of labs that will be checking with antibiotics. Obviously, the complete blood count with differential, CBC with diff. So we want to see the white blood cell count. We want to see the specific types of white blood cells, watch their percentages change. So that's going to give us evidence that the infection is worsening or improving. But what are some other labs? Well, we're going to look at kidney functions and liver functions. Because remember, some of these antibiotics are nephrotoxic or toxic to the liver. Nephrotoxic, toxic to the kidney. So that we look at the BUN, blood urea nitrogen, but we pronounce it BUN, not bun. I think I said bun is what you put around a burger or a hot dog. Creatinine or creat, C-R-E-A-T. Those are labs that test for kidney or renal function. And the BUN is more sensitive for acute or current damage. Creatinine is more sensitive for chronic or long-term damage. When they're both up, the person is having some serious problems. The liver, the most common labs tested for the liver will be the ALT and the AST, and these simply test for hepatic or hepatocellular or liver function. A lot of times they'll be called LFTs, liver function tests. It isn't really testing the ability of the liver to do things. What it's doing is these are enzymes that, as liver cells become damaged, they spill into the blood. So what's happening is the more those enzymes you see, the more you can infer that there is liver damage happening. So that's kind of it. ALT and AST are indirect measurements of any potential damage to the liver, whereas BUN and creatinine measure true function, current function. So again, for toxicities, hepatotoxicity, liver toxicity, hepato, that means liver, ALT and AST, kidney or nephro, the BUN and creatinine. We're also going to look for blood problems, not just the WBC, but we're going to look for anemia. Some antibiotics can cause bone marrow suppression and therefore the reduction of red blood cells. So we're going to look for the actual RBC or red blood cell count, and the hemoglobin and hematocrit. And those are measurements of, hemoglobin is a measurement of iron or heme in the blood, and the hematocrit is the percentage of heme in the whole volume. And I just noticed on the slide here that you might be seeing that the slide says HMG and it's actually HBG. We're going to look for leukopenia and neutropenia. Leukopenia, reduced white blood cells. Neutropenia, reduced neutrophils. And thrombocytopenia. Anything that says thrombo is related to clotting. In this case, it's platelets. And penia means reduced. So reduced platelet count. And those blood tests, the RBC, WBC, hemoglobin, hematocrit, and platelets are all found on the CBC. Also, hemoglobin and hematocrit are sometimes abbreviated H and H. So if you hear a doctor say get an H and H, that's what he wants. We have a lot of abbreviations, acronyms, shortcuts, and shorthand. I'll try to inform you as we go along. If I forget something, please ask me in class. So some nursing implications. We always assess for allergies. What do I mean by allergies? Do you remember? We talked about this last week. Hives, rashes, itching, swelling of the lips, tongue, or throat. That's called anaphylaxis. But the rash, the hives, and the itching can happen anywhere in the body. those are allergies. Nausea, vomiting, diarrhea, common side effects. We will still assess for them, but we're not going to panic when we see that. And we're going to teach our patients that these are common and expected side effects. It's kind of like the price you have to pay to get healthy. We're going to look at drug and food interactions. Sometimes some antibiotics, some medications interact with different foods. Remember we talked last time, grapefruit is a big one. Some antibiotics you can't drink with milk because the calcium will inhibit it. But all oral antibiotics are absorbed better if taken with at least 6 to 8 ounces of water. Water helps the breakdown. And ideally, you want to take antibiotics on a very specific schedule. If it's scheduled every 6 hours, you really should take it every 6 hours. That means waking up in the middle of the night to take some pills. Because remember, we talk about that therapeutic range. We don't want it to go down and keep going. We want it to stay up here. So that means keeping it in above that minimum effective concentration, but below the toxic level. If it says take it 1 time a day, take it the same time every day. We're going to teach patients those things. Take it exactly as prescribed for the exact length of time prescribed, and don't stop taking it early even if you feel good. Always watch for signs and symptoms of a superinfection. Fever, perineal itching, cough, lethargy, unusual discharge. Superinfections like C. difficile can be dangerous, and we want to catch that very quickly. We're also going to watch for pseudomembranous colitis, which is abdominal pain, bloody mucus diarrhea, and a low-grade fever. That's a very dangerous condition. Not very common. None of these are very common. But we want to watch out for them always because, the one time you don't check, that's when it's going to happen. Some other side effects. Now, there are other side effects that are not common and expected. Stevens-Johnson syndrome is really bad. It's a life-threatening condition. It's a hypersensitivity complex that affects the skin and mucous membranes. And there's some pictures here where the skin breaks and sloughs off. And of course, then you're prone to more infections. And it's a bad. I've never seen it, and honestly, I don't ever want to. Photosensitivity. Again, when you take antibiotics, you can sensitize your entire body, and some will cause easy sunburn. When normally you could go out in the sun for extended period of time, if you're on antibiotics, you can frequently sunburn very quickly. So you want to protect yourself, sunscreen, or cover yourself, or stay out of the sun completely. So antibiotics, quinolones, sulfonamides, sulfas, tetracyclines, these will all cause photosensitivities. Water pills, a lot of medications can cause photosensitivity. So that's a good teaching lesson. Now, the doctor will prescribe anti-infectives or antibiotics based on a number of things. Is there any allergies? Now, remember my story, I'm allergic to Biaxin. So my doctor can never give me Biaxin. Biaxin is a great medication for sinus infections. I can't take it. So now I have to take other medications that are not as effective and are generally more expensive, but I won't die from an allergic reaction, so that's good. And what type of infection is it? Is it E. coli? Is it strep, staph? What's going on? Each type will have a different category of medications, that will work. Where is it located? Is it deep inside and in an anaerobic state, or is it surface where it's aerobic? It may be that you just need like a topical antibiotic. You can go to the store and buy triple antibiotic. Those are 3 different antibiotics that are very low powered, but they work. What is the client's organ function? Do they have kidney or liver disease? If they do, that's going to change how much we give, how often we give, or even the type of medications we give. How old is your patient? Now, if it's any of you or me, that's really not going to be much of an issue. But if it's your grandparent or great-grandparent or it's your grandchild, that will make a big difference on how we treat this. Pregnancy or lactation. Some medications are teratogenic. Teratogenic. What does that mean? Come on. Teratogenic is any substance that can interfere with the normal prenatal development or cause one or more developmental abnormalities. That's right from your book. So we want to prevent birth defects. That's what we're trying to do. And a teratogen can cause a birth defect. So if a medication is teratogenic and your patient is pregnant or nursing, that's a problem. You have to take that into consideration. And if your patient is pregnant or lactating, no matter what, you're going to take care of all medications because you just don't want to take the chance of anything affecting the baby in utero or the baby via breast milk. And is there any likelihood of resistance to this antibiotic? Penicillin is a great antibiotic. It is really good, but there are so many things that are resistant to it now. So that has to be taken into consideration. So tetracycline, going back to the pregnancy, tetracycline is can't be used during the second and third trimester because it can result in damage to the developing teeth of the fetus. This is much less common now than when I was growing up back in the olden days. If you ever see a person that look like they have gray teeth, that may be that their mom was given tetracycline while they were pregnant, because that would cause a graying of teeth, and it's permanent. It's built into the teeth. Ototoxic substances like streptomycin can cause auditory nerve damage in the developing fetus. So you need to be very careful when your patient is pregnant. That's just a common sense statement. So, are antibiotics safe to take in pregnancy? What do you think? Here's a better question. Is the risk of the antibiotic greater than the risk of the infection? If the infection can cause more damage to the mother or child, then you take the antibiotic and chance it. That makes sense? Ideally, you're just going to stay healthy. So how do antibiotics work? Well, there's a number of ways. They can interfere with cell wall synthesis or the creation of new cell walls. They can interfere with protein synthesis or creation of new cells, DNA replication, or they can act as an anti-metabolite. So specifically, the cell wall synthesis is it destroys the structural integrity of the bacterial cell and the organism dies. This is also called a bactericidal, or it kills bacteria. Protein synthesis inhibition prevents the proteins from growing and reproduction within the antibiotic, or I'm sorry, within the bacteria. So the bacteria's, it doesn't kill the bacteria, but they can't reproduce. So what happens then is, since it prevents the infection from spreading, so the person's natural immune system, the white blood cells and all the helper cells, are able to go in and then take care of the antibiotic. These are called bacteriostatic. Bactericidal, killer. Bacteriostatic keeps it in one place. Static. If it interferes with the permeability of the cell membrane, this is usually bactericidal. It allows more things in and out of the cell membrane, so either the cell ejects contents and dies, or stuff gets in and kills it. That's bactericidal. And then antimetabolites, this blocks a specific metabolic step that's required for normal function of that bacteria. This could be bactericidal or bacteriostatic, depending upon the exact nature of the action. So those are a number of functions or mechanisms for antibiotics, all with the same end result. Several of them would kill, others stop growth to allow your body to kill it. And ideally, you need your immune system to work so that antibiotics work with it. So broad spectrum antibiotics are used when you don't know what the actual microbe is. Now there's a drawback. These also destroy the good flora in your body, the gut bacteria that you want. So this causes diarrhea possibly and superinfection. And a definition of a superinfection is a state in which organisms whose population is normally under control in the body begin to multiply rapidly as the antibiotic reduces the number of organisms that are normally the competitors. We all have bacteria in our gut, good and bad. We just do. That's normal. Normally we have many more good, and those many more good ones kind of ride herd on the bad bacteria, preventing them from growing. Some antibiotics will wipe out all the good bacteria, and then the bad bacteria throw a party. Next slide that we'll be looking at is simply a visualization of the different antibiotics that do different things. And I'm not going to read these. I want you to go look at this slide, but this shows you exactly which type of antibiotic works where. And again, bactericidal, cephalosporins, polymyxin, vancomycin. These are the bacteria killers. Remember, cidal means death. Bacteriostatic, sulfonamides, erythromycin, lincomycin. These keep bacteria from growing. Bactericidals are almost always used when the infection could be life-threatening, or if the person's immune system isn't working properly. If your person is essentially healthy and they just have a minor infection, sinus infection, UTI, they'll give bacteriostatics because remember, it prevents the growth. It will not kill off the good bacteria in the gut, and it lets your normal immune system take over and finish off the fight. But if we're talking a serious bad infection, we're going to hit them with the bactericidals, and then we're going to watch out for side effects. Now, some of the antibiotic classes: sulfonamides, beta-lactams. Now, there are some antibiotics that have beta-lactamase, and the reason why that's important is beta-lactamase is an enzyme that inactivates or eliminates the beta-lactams. So penicillins, some cephalosporins. So if you're attacking a beta-lactamase positive antibiotic, you have to use different medications. This is what the doctor will worry about. But we need to understand why we use the medications we use. Tetracyclines, and there's that whole list of the antibiotic classes, and I'm not going to read all of them. But let's talk about some other other specific illnesses. Tuberculosis. We all, before we do our clinicals, we have to have our TB test where they put the little wheel of the TB serum and they look for a reaction. It's Mycobacteria tuberculosis. It's a rod-shaped bacilli. It's transmitted from humans, cows, or birds, and it's airborne. So it's really easy to pass. Not easy to catch, but easy to pass. It's a very slow-growing bacteria. So, and a lot of times, bacteria become dormant and walled off by tissues, and these are called tubercles, or that's how tuberculosis got its name. Tubercles could be in the lungs or almost anywhere, but commonly in the lungs. And a person can have the mycobacteria in them, but not have the illness yet. Later on, if they have another illness or another stressor, those tubercles can break down and then they become infectious. Anti-tubercular agents. Well, there's a lot of primary agents, which are INH or isoniazide, rifampin, and they're all on this slide here. The problem is about 33% of patients in New York City were recently found to be infected with TB that is resistant to at least one of those anti-tubercular drugs. If people have multi-drug resistant TB, the mortality rate is 72 to 89%. In other words, 3 out of 4 people will die if they have multi-drug resistant TB. There's an example of how drug resistant bacteria have gotten really bad. Isoniazide causes ototoxicity. It can also cause peripheral neuropathies. And when a person takes this, if you're ever working with a patient who has this, you'll know they're taking their medications when you empty their urinal or check the toilet, because the urine will be reddish, as well. Well, okay, not just their urine, but their sweat, their sputum, and their tears will all be reddish. And the first time I saw that, it was pretty weird. It really was. You'll want to watch BUN and creatinine, liver studies, and a complete blood count for these medications. Now, if we're going to do generally a multi-drug therapy, never just one for tuberculosis, because it is a tough drug to kill. It's slow growing, and anything that's slow growing is hard to kill because it just takes so much longer to absorb things. So we're going to use multiple drugs, usually 2 to 4 drugs at the same time, for 6 to 12 months. 6 to 12 months of daily drugs that cause you to cry red, sweat red, pee red. People stop taking those drugs and then they become drug resistant. Rifampin will also cause red discoloration of body fluids. If something to teach your patients, if they're on this, and they wear contacts, they will have to stop wearing contacts until they're done, because the tears in their eyes will stain their contacts red. So we just talked about patient teaching, nursing considerations, teaching the patient the importance of taking the medications at the right time for the entire length, monitoring lab values, monitoring any super infections. So those are that's how we take care of tuberculosis. It's not common in our part of the country, but it is. We do see it occasionally. If you have a patient with tuberculosis in the hospital, they will be in a negative pressure room. That's a room that is drawing air out of the room, so that when you open the door, bacteria don't go into the hallway, but instead air rushes into the room, protecting everybody in the hallway. This segment is now at 24 minutes. We're going to stop now, pick it up, come back for part 3.